Hello, everyone. Colorectal cancer is one of the most common and deadly cancer worldwide. It often begins as polyp in colon or rectum, which can turn cancerous over time. In India, the 5-year survival rate remains below 40%, largely due to late diagnosis. Symptoms like change in bowel habits, rectal bleeding, unexplained weight loss, and fatigue often goes unnoticed until the disease has progressed. Early detection through screening methods such as colonoscopy and stool tests significantly improves survival rates. Diagnosis involves imaging, biopsy, and molecular testing, while treatment options include surgery, chemotherapy, radiation, and targeted therapy. Lifestyle changes, including a healthy diet and regular exercise, can help reduce risk. As a part of Colorectal Cancer Awareness Month, Voice of Healthcare, in collaboration with Merck, is hosting this special session, a dialogue on colorectal cancer. This initiative aims to raise awareness, educate the public on prevention, and encourage timely screening to improve outcomes and save lives. Join me in welcoming our panelists for the day. Dr. Sunil Kumar Gupta, Principal Director and HOD, Department Haemato Medical Oncology and Bone Marrow Transplant, Venkateshwar Cancer Center, Delhi. Welcome, Dr. Sunil.
Thank you, Dr. Manisha.
Dr. Professor S. Rajasundaram, Director of Oncology Department, Gleneagles Health City, Chennai. Unfortunately, he won't be joining us. He's not well today. Dr. Kripa Bajaj, Consultant Medical Oncologist and Cancer Genetic Specialist, KIMS Sunshine Hospital, Hyderabad. Welcome, Dr. Kripa. Dr. Shasanka Sekhar Das, Consultant Medical Oncologist, HCG Cancer Center, Kolkata. Welcome, Dr. Das.
Thanks, ma'am. Thanks.
Dr. K. Madan Gopal, Advisor, Public Health Administration, NHSRC, Ministry of Health and Family Welfare, Government of India. He would be joining us. So I am Dr. Manisha Khurana and I'm your host for the day. So I'll start my session with Dr. Sunil. What is colorectal cancer, sir? And what are the current trends in colorectal cancer incidence and mortality in India? Are we seeing any increase in early onset?
Dr. Manisha, your question is having three segments, I tell you. The first question is, what is colorectal cancer? And once we are talking about colorectal cancer, I say rectum is a different disease and colon is a different disease, and combined we will say colorectal cancer. The lower portion of the colon is known as a rectum followed by anal canal, but I divide colon into three parts. The cecum basically have a ascending colon, transfer colon, and descending colon. Colorectal malignancy is, if you see globally, is the fourth most common disease in the world. But if you see the Indian scenario, this is the seventh most common disease in our clinical practice. If you see the colon cancer is much less as compared to the Western world. As you mentioned about that, there is a presentation difference. If you are having a right-sided colon, the presentation of signs and symptoms are different. If there is a left-sided tumor, the presentation of disease is different. I would like to say that few factors are very important in colorectal malignancy. And the important thing is a red meat or a processed meat, alcohol, tobacco, or sedentary lifestyle, obesity, metabolic disorder. Even the heredity play important role in colorectal cancer. If you see the family history is seen in 20% of the patients of colorectal malignancy, and out of that, 2 to 4% patients are having a Lynch syndrome, which is one of the culprit in number of colon cancer. If you see the inflammatory bowel disease, the ulcerative colitis, Crohn's disease is one of the risk factor in due course of a time. Means if patient is having a history of inflammatory bowel disease like ulcerative colitis or a Crohn's disease, 20 years later, the chances of colon as well as rectal malignancies are very high as compared to the normal population. So the important thing is that which factor is responsible for this? I personally feel red meat and processed meat is one of the major culprit in Western world of colorectal malignancy. As you mentioned about that, the presentation is routinely the rectal bleeding, abdominal pain, unexplained weight loss, change in bowel and bladder habit. I would like to add sometime there is a distension of abdomen due to ascites. There is a pain, severe pain in the abdomen because of the perforation and obstruction of the tumor. These are the common presentation in our clinical practice. If you see in India, we found always colorectal malignancy in an advanced stage. As you mentioned very clearly, as compared to the Western world, so early diagnosis through screening is very crucial in colorectal malignancy, and CRC is highly treatable in the early stage. We can talk about a curative intent treatment in majority of patients up to stage 2 means surgery, and there is no treatment until some poor risk factors are involved for adjuvant treatment. If you see the incidences of colorectal cancer is changing in 2024 and 2025. If you see the Indian data, they mention about that approximately age standardized incidence rate is 4.3 in 1 lakh population in male as compared to 3.2 per lakh population in female. While if you see the Western world, if you see the 2024 US data, they mention about more than 1,06,000 cases diagnosed of a colon cancer and approximately 46,000 cases diagnosed of a rectal malignancy despite of multidisciplinary approach. 50% mortality reported. And you mentioned very clearly that 5-year survival in India is less than 40%. This means despite of surgery, radiation, medical oncology treatment, and now the new treatment like checkpoint inhibitor and targeted therapy, the mortality is very, very high. I would like to show you some Globocon data. If you see 2020 Globocon is published the colorectal malignancy data. They mention about that approximately more than 27,000 new cases diagnosed of a colorectal malignancy, and approximately 50% were male and less than 50% is female, and approximately roughly more than 50% patient despite of multidisciplinary approach mortality reported. The important thing is that our habits play important role. Suppose we are having a obesity, we have a sedentary lifestyle, we are using the junk food, we are having alcohol, pan masala, or you can say the red meat in our day-to-day life, chances of colorectal malignancies are very high despite of prevention. Prevention is very important for all the cancer. We are having a low fiber diet, we are not eating the balanced diet, and that's why the colorectal malignancies are very, very high. Just see the pattern of disease, colorectal malignancy. The Western world, incidences of colorectal malignancy more than 65 years of age is decreasing pattern for last 3 and 4 decades. This is very important message I want to convey you. As per the US data, for last 3 decades, approximately there is a decrease 1 to 2% colorectal malignancy if the age is more than 65 or equal to that. But the pattern of colorectal malignancy is different. When 50 to 65, there is a decrease, but not like more than 65 to 60, more than 65 years. But if you see the young age means less than 50, or I personally believe less than 45 years of age, the cancer of colorectal malignancy is having two different things. The histopathology is different. Genetically, they are different. They are responding poorly to the treatment. Recurrence is very high. Mortality is very high. Outcome and 5-year survival is much less in less than 45 year of old man and woman as compared to those who are above 65. Means this pattern of disease is different, and nobody knows about the histopathology of this. Why this is different? We believe that the basically a genetic basis or a molecular diagnostic basis, some difference in tumor biology which play important role in India as well as in Western world. I would like to say that the pattern of disease is always behaving with the left side versus right side tumor. If right side tumor, colorectal malignancy, the outcome as compared to left side tumor is poor. The right side tumors are not responding very well with the chemotherapy, the outcome, the targeted therapy, as compared to left-sided tumor. I would like to say, despite of low incidences of colorectal malignancy in India, but the large population, the number of cases are very high, acts like Western world. The tumor biology is different, pattern of disease is different, outcome is different as compared to Western world. If you see in US, non-Hispanic Americans are having a highest incidence of colorectal malignancy, while the Indian Asians in American sites are having a less incidence. So the pattern of disease is heterogeneous. I would like to say colorectal malignancy is a heterogeneous cancer. As you mentioned about polyps, polyps in due course of a time turn out to be malignant, but we need a regular follow-up by colonoscopy or by CEA. If you feel that there is a family history of malignancy in the family, always go and check by the screening methods or preventive methods in clinical practice. This is my opinion, Dr. Manisha.
So very well explained, and this is quite astonishing that the data which you have presented to us, and you have told rightly told that red meat and eating habits, less of fiber, and ulcerative colitis, Crohn's disease, all these are predisposing to development of these cancers, and trends are changing, and we need to address that. Right, sir. Dr. Das, what are the major barriers, clinical or socioeconomic, that hinder early diagnosis and treatment in colorectal cancer?
Uh, as my previous panelist has elaborated the epidemiology of the colorectal cancer very nicely, sir. Thanks, sir. And the epidemiology and the positive factors. And so the thing is, as sir has elaborated, and many time had told, I remember, we usually come across the colorectal cancer at a very advanced stage. And are coming into the advanced stage. And in fact, in India, the demographic pattern of the disease is also slightly different from the Western countries. In India, the age at which we diagnose colorectal cancer in India is very is lesser compared to the Western world. In Western world, the average age is above 50 to 55 years, means, while in India, the younger age group, the colorectal cancer is rising trend. So in younger age group, obviously, the patient who are in the younger age group are always in a rush life, hurry life. So they tend to avoid the regular symptoms which we come across in day-to-day life, and those can mimic the colorectal cancer as a whole. Because you have initially in your talk has talked about the alternation of the bowel habit. In many patients, in day-to-day life, we come across maybe in patient with irritable bowel syndrome who have a alternation in bowel habit regularly, but they don't go to physician, they don't go to any surgeon for their checkups, and those cases can be missed easily. And those cases, when come to a clinic, when come to our clinic as a oncologist, we see those cases are come. Those cases come as a very advanced disease with, and in fact, colorectal cancer at the younger age group is a very advanced, it as a very aggressive disease. I think sir will also agree with me that colorectal cancer in the younger age group, the prognosis is bad compared to the elderly age group, because in those patients, the resistance to the chemotherapy, the resistance to the targeted therapy also happens, and so in in the age group of younger age group, that it's difficult to treat patient with colorectal cancer. Secondly, the colorectal cancer, the mainly in the rectal cancer or in the left-sided colon cancer, there is some socioeconomic, social stigmata, because patient usually undergo surgery, and they have been advised surgery for from the surgeon, and in fact, the surgery.
Dr. Das, I can't hear you. Yeah,
So
please.
yes, I think there's some network issue, and
Yes.
there is a colostomy always being advised, either permanent or a temporary colostomy. So that 40-year-old young guy walking with a colostomy bag, it's a bit social stigmata for an Indian patient compared to a Western.
Okay. I think there's some network issue, Dr. Das. All right. Okay. So I agree that change in bowel habits should not be overlooked, and even slight bleeding, these symptoms should be addressed. And you told us that youngs,
Hello.
they, yes, Dr. Das, yes.
Yes, and the thing is that many patients tend to avoid surgery at earlier stage and tend to avoid surgery because in my clinic only younger patient coming, I tend to tell them for surgery. Try, they tell, okay, is there no alternative to surgery? Because nobody wants to go for the stoma. Okay. So that is again a factor for challenging issue of treating a colorectal cancer at a younger age. Thirdly, the economic constraint. The economic constraint is also a factor because in mostly in a metastatic cancer where the treatment paradigm has changed a lot, coming to the targeted therapy, the immunotherapy, and the advanced treatment which we are coming across, those are literally lacking in India because our, I think, only 20% patient in our clinic can afford the advanced treatment which being offered to the Western world. So these are the challenges we face in our day-to-day clinic while managing the colorectal cancer as a whole.
Right, sir. Dr. Kripa, are you there?
Yeah, ma'am, I'm very much there.
All right. So I'll take up your question. I would like to ask you that how crucial is routine use of molecular diagnostic and genetic testing in optimizing the colorectal cancer treatment, and how important is genetic counseling along with it to address the hereditary colorectal cancer? And are Indians aware of all these?
Right. So, I used to head the cancer genetic clinic, madam. I'm heading right now in the current, I established the current cancer genetic clinic. Compared to previously, like almost like down the line 4 years before and now, there is a rampant increase in the awareness regarding genetic testing in colon cancer. Previously, it was a stigma to be labeled as a person having a genetic risk for colon cancer, but right now, families are coming forward to understand the risk. With the availability of pre-implantation genetic testing, many females are coming forward to understand their genetic risk compared to the others because there is a family history of cancer running in them. So I do day to day, weekly, at least 3 to 4 patients I'm testing for. 4 people I'm testing for the hereditary testing, cancer testing, for especially colorectal as well as the BRCA testing. So 6 samples in a month I'm sending.
All right. So they are aware of it, and awareness is increasing, and definitely with the advent of pre-plantation genetic testing, they are going in for all these BRCA testing, and they want to know their cancer risk, even in the colorectal cancer as well, right?
Absolutely,
Doctors,
absolutely, and
yeah,
it prognosticates many aspects.
correct, correct. So, Dr. Sunil, how have treatment protocols for colorectal cancer evolved in India over the last few years, especially with the introduction of targeted therapy and immunotherapy?
Dr. Manisha, if you see, there is a evolving field of a treatment of colorectal malignancy. Means people are talking about a molecular diagnostic test, and in last 1 decades, we are having a different targets in a metastatic disease of colorectal cancer to add with cytotoxic drug. Routinely, we are doing the, as Dr. Kripa mentioned about very clearly, that molecular diagnostic tests are very important in metastatic disease. Once we are talking about role of targeted therapy, checkpoint inhibitors, or any target with combination with cytotoxic drug. Routinely, few tests we are doing in all the patients, like pen rash, PDL1, MSI, MMR. We are going for BRAF, hernia receptors study to see which target is positive in clinical practice and adding of particular target with the cytotoxic drug, whether this is a Folfox or previously received Folfox and Folfiri or any addition of that. The important thing is that the right-sided and left-sided tumor also play in this. The right-sided tumors, if there is a disease which is not having a mutation, you can go for a only bevacizumab combination with the cytotoxic drug. But if left-sided tumor, you can go for a anti-EGFR therapy like cetuximab, panitumumab combined with the Folfox or Folfiri. Totally a new concept now. But if you see cetuximab, we are using for last 1 decade. So I'm using for last 1 decade. The new thing is the pembrolizumab and nivolumab as an option in a PDL1 positive patient, and this is the new concept now, known as a checkpoint inhibitors role in colorectal malignancy. The important thing is that whether patient can afford or not afford, you are doing these molecular diagnostic tests in all metastatic colorectal malignancy and advising the targeted therapy or checkpoint inhibitor with combination of chemotherapy as a standard of care in metastatic colorectal malignancy in 2025 as in a treatment option.
Right, right, sirs. That is good to know that there are so many molecular tests available, and especially in metastatic cancers, they can be done, and we have the targeted therapy and immunotherapy available, and especially for later stages, and survival can be improved with the help of these newer drugs and newer therapies. So, Dr. Das, how effective are patient education program in addressing misconception about colorectal cancer treatment?
Uh, yes, ma'am. So obviously, patient education program is a very always required because the patient, as I had told, that the treatment comprises of the initial stage, the treatment comprises of surgery followed by chemotherapy, and if it's a rectal cancer, we sandwich radiation therapy between the chemotherapy, either before the surgery or after the surgery. So that was the treatment goes. So it comprises of around 8 months of total treatment, 8 to 9 months of total treatment, which the patient has to endure, and that treatment again, the surgery comprises of big surgery with eventually the patient lands up with either partial or complete or mm, permanent or temporary colostomy. So that is a stigmata to the patient. That is a very social stigma to the patient. So educating the patient to deal with the truth, to deal with the harsh reality, it's very challenging. One thing. Second thing is during the treatment. During the treatment, the patient will have severe many side effects, mainly the neuropathies. The treatment protocol mainly comprises of the platinum oxaliplatin, which have a significant neuropathy at the down the line, maybe in the earlier phase, and again the delayed neuropathy. So the patient have to live with the neuropathy for the quite a long time, and for that, a patient education program is a very good initiative. Second, and thirdly, and in the in the metastatic setting, where the patient have to live with the treatment for the lifelong, maybe some form of treatment till the lifelong. In those patients, giving a patient education program is always important because adherence to the treatment is very important to have a good overall survival and good progression free survival, because we have seen in various data that patient who adhere to the treatment and patient who take all forms of treatment which are currently available for the colorectal cancer tends to have the highest overall survival than patient who cannot take, maybe due to the financial issue, maybe due to the his health, his clinical issue, tend to have a poorer prognosis. So obviously, patient education program holds a very important role in management of a colorectal cancer, either in the earlier stage or in the metastatic stage.
Right, sir. Dr. Kripa, do you see a role of AI-based diagnostic tools or decision support system in enhancing early diagnosis or personalized treatment strategies for colorectal cancer? Please unmute yourself.
Future is based on, yeah, I unmuted. So future is based on the AI. So we know early breast cancer, how important it is, the tools. We are using many tools in the early breast cancer to stratify like whom to offer immunotherapy, whom to offer chemotherapy, like that. So just like that, we know it's a spectrum of disease in colorectal cancer. We know MSI high, how variant it is. Now in future, the adjuvant immunotherapy might come, or some people might not require chemotherapy. So these kind of patients, the AI will play a very important role. It's stage 4 things are clear, and stage 3 things are clear. But early stage, a lot of discussion is there, a lot of new data is coming up, especially in rectum as well as the colon, and more than anything else. So in this area, the AI will play a major role, and the gene signatures and the AI is going to be the future in management of the malignancy.
I think we had some audience questions as well. Can you display on the screen, Bagan team? Do we have some questions? So what is the difference between colon cancer and the rectal cancer? Dr. Das, can you please explain?
Yes, as Sir has initially very nicely explained that, and again I am repeating that the colon comprises of the part beyond the this colon comprises of the ascending colon, the transverse colon, and the descending colon. The descending colon, the terminal part of the descending colon, where it ends, from that part it starts the rectum and the eventually the anal canal. So the terminal part of the descending colon is called the sigmoid colon. So up till the sigmoid colon, the cancer is called the colon cancer, and beyond the sigmoid colon, where the rectum starts, it's called the rectal cancer.
Right. So we should know the anatomy of large intestine first to understand it, right? So what are the challenges patients face? As far as the surgery is concerned for colorectal cancer. So Dr. Sunil, please tell us.
Means Dr. Manisha, as Dr. Das clearly mentioned about that, there is a difference between the rectal malignancy treatment versus the colon cancer treatment. If you see, I divided rectal malignancy in two parts, the upper rectum or lower rectum. Upper rectum, you can spare the permanent colostomy. You have a divergent colostomy in the beginning, and you can 6 months later you can go for a closure of the divergent colostomy. But in a lower rectum, you need a permanent colostomy for a patient. As Dr. Das mentioned clearly, sometimes this people feel this is a stigma. Okay. The rectal malignancy is different in the sense of a treatment also and surgery point of view also. We are going for a stapling surgery in rectal malignancy. We are going for a permanent colostomy. While in colorectal malignancy, we are having a hemicolectomy or lymph node dissection and removal of the tumor. Okay? And there is no need for divergent colostomy unless obstruction or perforation seen. The important thing is even the treatment part, rectal malignancy, you can need a radiation plus chemotherapy. If T3N1 disease, you can go for a initially the chemoradiotherapy pre-operative followed by surgery 6 weeks to 8 weeks later. While in a colon, we can go for a NACT if surgeon feel difficulty in surgery, or you feel that the disease is diffuse, then NACT, otherwise upfront surgery, followed by adjuvant treatment. The important thing regarding colorectal cancer is that the right side versus left side, the surgery depend upon the tumor size, location, whether perforation, obstruction, ascites, nodal disease, totally depend upon these factors. First chemotherapy followed by surgery or upfront surgery is a discretion and should be discussed in a multidisciplinary approach or in tumor board if there is a diffuse disease. Always discuss with the surgical oncologist, medical oncologist, radiation oncologist, pathologist, and our radio diagnosis people and PET people regarding the stage and disease, and depend upon that you can decide about the surgery versus the other options. The rectal malignancy behavior is different as compared to colon. Rectal malignancy is seen in young patients. The tumor biology is different, aggressive, recurrence is very quick within 2 years period in young patient, those who are 35, 40 years of age group. And tumor biology is different, and mortality reported despite of multidisciplinary approach. So tumor biology is different, and we are identifying the cause. What is the real cause? Whether there is a molecular diagnostic which is play important role for such tumor biology. Second thing, Western world disease versus the Asian patient disease. Western world disease is slightly different from the Asian patients, and I personally feel that in India we have a more locally advanced disease or a metastatic disease as compared to Western world because of two reasons. The screening methods we are not following in India. Preventive methods we are not doing in any cancer, even in the colorectal malignancy. And we are not changing our lifestyle, the food habits, the metabolic disorders, diabetes, obesity, junk food, processed food, red meat. Means these are the culprits of colorectal malignancy and commonly seen even in the Western world. If we change, we are taking the high fiber diet and avoiding the junk food or a alcohol, tobacco product, red meat. Definitely the colorectal malignancy is much less. Even if you compare with the Western world, we are having less cases as compared to Western world. But tumor biology is different. Even the surgical aspect is, and treatment option in both rectal and colon is different.
So we have one more question, that how can we reduce the risk of developing colorectal cancer? Dr. Das, can you please take up this question?
So, as rightly said by Sir, that colorectal cancer, the predisposing factor, the risk factor of colorectal cancer are always at mostly are the lifestyle factors like food habits. We used to have junk food, red meat, high low fiber food always. So taking a high fiber food, avoiding red meat, avoiding alcohol can reduce the risk of colorectal cancer. One thing. Second thing is genetic factor. The genetic factor can be the genetic risk factor can be reduced by proper screening and testing yourself for the genetic disorder if you have, and if you have the genetic disorder, get it screened and tested for yourself for reducing the risk. Thirdly, the family risk factor, that patient with a family history of colorectal cancer have a higher risk of developing a colorectal cancer in himself. So in patient with family history of colorectal cancer, try don't to avoid the small clinical or symptoms like alternation of bowel habits or sudden reduction in weight. Try to go for the screening from a good physician, and that by that reason, way we can decrease the risk of colorectal cancer.
Right. So by changing our lifestyle and having more fibers can help us reduce the risk. How often should one undergo screening for the colorectal cancer, Dr. Kripa? If you can explain a little bit, if you genetic, okay, you tell me about the genetic screening. Rest I can
Right,
discuss
right.
with the oncologist. Yes.
So usually the screening depends on the history of the family history of the malignancy. So if our patient has a significant family history and patient was tested positive for any genetic condition. So usually we try to place screening 10 years younger. For suppose family member has a cancer at the age of like had cancer at 50 years, try to start screening at the age of 40 years. So likewise, we will schedule. First thing is whether the patient is positive for the gene or not, we have to check. So the for the viewers who are like following this, if ever any person is having a family history, if we want to understand there is a predilection or not in the family, we will do the germline testing. Germline testing is the testing which is done on the blood sample. We will do on the blood sample. So if it is positive, we'll schedule the screening as per the youngest member of the person who got affected with the cancer. If it is not so, as per the population, we will just see the, for suppose North Indians have a different prediction and South Indians have a different predilection, and like West side and East side, there is a different predilection for having a colon cancer. If the population is at higher risk, better we place the screening schedule slightly younger.
Right, right, sir. Dr. Sunil,
Better
uh,
we place at a slightly younger age. So in
huh, right,
generally, this colon cancer screening, we are doing occult fecal test. We are not doing a routine colonoscopy for everyone. We are offering occult fecal test once a person crossed 40 years of age. So colonoscopy in a very specific population, just now how I mentioned, there is a family history and all who are proven positive, those patients we are doing it. Otherwise, we are not really pushing to undergo colonoscopy. We are doing occult fecal test for the blood, any passage is there. And also tumor marker, serum CA, usually that comes with a package in most of the hospitals. Otherwise, colonoscopy is a tedious procedure, invasive procedure, all of us know. We will offer only when there is a high risk in the family concern.
right. So, occult fecal blood and CA, they are important tests and they can be used for screening, and colonoscopy can be decided depending on the risk. Right. Dr. Sunil, there's one more question. Okay. Is lifestyle choices exercise, smoking, alcohol, they affect the risk of developing colorectal cancer? I think this is yes, it has already been discussed. All right, I'll take up one clinical trial question with Dr. Sunil, that what is the current scenario for colorectal cancer clinical trials in India, and are Indian patients well represented, sir?
Please, Dr. Manisha, if you see, I am doing clinical trial for last 3 decades in India. The issue is that majority of time the clinical trials are sponsored by the industry. And whenever you are having a industrial based clinical trial, the innovator country always see the magnitude of disease in particular geographical area. If you see colorectal malignancy, this is a Western world disease more as compared to the Asian. We have a large volume of population, and despite of that, we have a large number of cases. As compared to the Western world, the number is almost, you can say, equal, but the number of cases are less as compared to Western world. Majority of time, if any Indian company develop the biosimilar, my word is biosimilar of the product, then and then they are doing the clinical trial in India. Otherwise, we are lacking in this in colorectal malignancy as compared to other diseases which are more common in India. So the clinical trial in India is totally depend upon the industry, the geographical magnitude of the disease, selection of the country by the particular sponsored industry who develop the innovator drug. I'm giving an example to you. When the Roche company basically developed the bevacizumab, means Avastin was the drug, they selected for a clinical trial to use in a right-sided versus left-sided tumor. And if you see the real-world picture, the clinical trial in colorectal malignancy in India is not much as compared to the Western world. But in other disease, we have lot of clinical trial. I'm doing clinical trial in lung now because of one of the innovator sponsor want that we would like to see the Indian population result in particular drug. But yes, we are doing clinical trial. But if you see the number of cases are less, that's why the clinical trial in colorectal malignancy is less in India as compared to the Western world.
All right, sir. Dr. Das, what support system are crucial to helping colorectal cancer patients in tier 2 and tier 3 cities navigate their treatment and their survivorship? Dr. Das. Dr. Das, can you hear me, sir?
Hi, yes, yes, I can hear you.
We have been talking about the social stigma, and
Hmm.
so I would like to ask you that how important is the support system here, because there is a social stigma attached with the left-sided, cancers.
Hi, yes, that is a very good question. So the thing is, the social support. One thing is any cancer patient, maybe it's a colorectal cancer or any other cancer, will require a social support for lifelong because the patient has gone a serious issue in the maybe in the 1 year or down the line 2 years of his or her treatment. So that part of the of his or her life is always being in a dark shade. So he always requires a social support. Maybe not in the financial support, but in a mental support also. So that is one point. Second thing, for a specific colorectal cancer, so patient living with the colorectal cancer, as I had told, many patients have to live with the permanent colostomy. So giving providing support of colostomy bag and colostomy that and colostomy site dressing is a very helpful to the patient. I have seen in my personal experience while working in EMH that many patients go haywire where to find the colostomy bag because the bags are not available easily in the open market. So, getting them with the colostomy bag and colostomy site, dressing material is a very helpful initiative, I think. Second thing is the chemotherapy part. After the chemotherapy, many patients goes have a peripheral neuropathy. So, helping them with the um, various hand exercises, material, and the educational material that this you have means you have to bear with this for a quite long time can help him lessen the pain of and the suffering. Second thing, third thing is during the treatment of colorectal cancer, many patients develop a hand foot syndrome, which is a very bad complication of day-to-day colorectal cancer management, and that management is a the management of hand foot syndrome is a basic management because the treatment is usually the supportive care, usually with moisturizer, usually with proper covering of the hands and feet. It can relieve the symptoms of the patient. So in that way, we can go we can reach the patient and we can have a good clinical outcome and we can give a good clinical outcome to the patient as a whole in this few small steps.
Right. So colostomy care as well as the stigma attached to it. I think the surgery requires social, support and the family support as well as the care which is needed post surgery. Right. Dr. Kripa, what are some promising advances in precision oncology for colorectal cancer that you believe can be made more accessible with the pharma partnerships?
Right. So, other panelists, rightly mentioned, Sunil sir as well as Dr. Shasanka Das. So, there is a quite an advancement in colon cancer regarding precision oncology. Precision oncology is nothing but personalizing the treatment to the person. As sir rightly mentioned, there is a wide variety of treatment between the wide variants of the treatment within the right side as well as the left side between two entities in a very altogether separate entity. So in colon cancer, targeted therapy and immunotherapy plays a crucial role. There are some predictive markers what we test on the tumor sample as well as the blood sample, and we choose the treatment accordingly. So coming with the advances of this, like we have a BRAF and RAS like evaluation. As per that, we will give the EGFR inhibitor targeted therapy, and other is the bevacizumab, the VEGF inhibitor, the Avastin, what Dr. Sunil mentioned. So this will be chosen as per the some molecular analysis, and also as per the some protein test, immunohistochemistry, and some germline testing. We will try to offer immunotherapy. So based on this, the patient will have a drastically good responses compared to chemotherapy alone. Chemotherapy is just like a backbone in the management of the colorectal cancer. If we want to enhance the outcomes, we have to add on the recent advancements. To add on this, which patient will respond to which therapy, will be able to understand by doing the molecular analysis of the tumor. So different tumors will have a different genetic polymorphism. So as per that, we will choose it. So this is a future to go, and the pharma company has to offer the free coupons. There are certain pharma companies which will give a very subsidized price for evaluation of this. So this has to be more robust. This has to be more, cheap than what it is now. So with this, we can understand which patient is the right patient to select. And whenever we ask this pharma company says the treatment is costly, why can't they spend 30,000 more? But that will motivate the patient to go for the right treatment. They'll understand the importance. Sometimes people will have the money, but they will not have a right knowledge to do or not. So by doing the test, they also will understand what is the importance of this test, why we have to take this treatment. And also good patient assistance program for people who are not really affordable will help more make people accessible. The study from Tata Memorial Hospital showed that very few people are able to take in spite of the good patient assistance program. What are the current patient assistance program? More and more generic entry and more patient assistance program will improve the landscape of treatment of oncology patients in the India as well as the world.
Right. So, before I conclude, I would like to have key message or advice from each one of you that you would like to share with colorectal patients and their families, especially those facing advanced stages of the disease. I'll start with Dr. Sunil first.
Dr. Manisha, means if you see the colorectal malignancy is a different one and need a family support as well as support from all, as Dr. Das mentioned about very clearly, because sometimes there is a permanent colostomy, and you need that how you can apply the colostomy bag, what are the precautions you will take during the journey once you are moving from one place to other place, and what are the supportive things required during the chemotherapy. The chemotherapy is basically for 6 months in adjuvant setting in colorectal malignancy, or you can say if you are going for a capsule based or injectable based chemotherapy, minimum 8 cycles of chemotherapy in adjuvant setting are required. So basically, the treatment of colorectal malignancy required surgery plus chemotherapy, almost 8 months time required for treatment point of view, number one. Second thing, you need a regular follow-up for early 2 years. Colostomy bag training is must once you are traveling anywhere in India or outside India. You must know how to apply and what precautions you will take. So the important thing is that despite of treatment, you need a day-to-day practice to learn about how to handle the colorectal malignancy with diet, with precaution, with side effect, with colostomy bag during traveling or in office time. This is the message I want to convey to the public. And regularly you need a tumor marker to see whether there is an increase or a static value. Increase in tumor marker, indicator of a recurrence of disease, and should be checked properly time to time.
And anything about, sir, precision oncology, upcoming newer drugs, which you want to convey to the public that they can be used?
Dr. Manisha, if you see precision oncology, as Dr. Kripa Bajaj clearly mentioned about that, we have so many targets. And the precision oncology means you are hitting the targets, you are hitting the receptor, you are giving the checkpoint inhibitors. The new concept is that in a colon, initially there was no HER2 receptor we checked. But nowadays we are checking the HER2 receptor and PDL1 and MSI or MMR for the checkpoint inhibitor like pembrolizumab role and nivolumab role, even the HER2 receptor blocker. So this is the new concept which was not seen 10 years back. Means if you see, I always prefer a pen rash, wild type rash versus the mutation. If wild, I am going for anti-EGFR therapy, and if mutation, I am going for bevacizumab. But now we are having a different targets in precision oncology, and I hope so that in future we are having a more targets, and we can talk about a curative intent treatment despite of a metastatic disease with precision oncology in colorectal malignancy.
That's a very good message, and we should always aim for the curative treatments. Thank you so much. Dr. Das, your closing message.
So, as Dr. Sunil has elaborately told about, and so we have means in every colorectal cancer patient, the patient has to bear with the pain of the treatment for the lifelong, and that's how he try to acclimate as the days goes by. But there are evolving treatment approaches like coming of the immunotherapy and coming of the targeted therapy into the picture, which might be in the upcoming days can have a good role to play in the treatment of colorectal cancer, and we can avoid giving the traditional chemotherapies in the long in the and maybe in the down the line after maybe 5 to 6 years we may avoid giving the chemotherapy that we can hope so, because how rapidly the treatment paradigm has is changing day by day in the colorectal cancer. We can hope so that we can give the patient a good life and good and and another thing for the surgical part, there is a evolving concept coming into the that patient with rectal cancer with after a chemotherapy and a radiation therapy, if there is a radiological response can be observed and they don't require they don't require surgery and stoma, so that can be a good very fruitful outcome to the patient, because giving a patient of the colostomy, permanent colostomy, is really a bless to the patient, I think. So the treatment is evolving, and let's see whether in the next few years we can give a better life and better outcome to the patient as well.
Right, sir. Dr. Kripa.
Right. So most of the times when patient has to undergo colostomy, he'll get terrified and he will not undergo, or he or she will not undergo, and will take a quite sometime before they go for native therapies. So to all the viewers who are listening, native therapies are not the way to go for any cancer, not just colorectal cancer. If ever something is like going to hamper you, something is going to handicap you, you have to accept this and go forward with lot of confidence and courage. So I always explain my patient that if ever you are going on the road, some accident must have suddenly had happened, you will just take it as the life comes, like that. So cancer surgery sometimes may leave or may make you handicapped in certain ways. In colorectal cancer, in urological cancers, it might like handicap you. But please don't get disheartened and try to get the right treatment at right time. You all know that right treatment at a right stage will lead to cure of the cancer. It's so often for us to see in all the clinics and hospitals patients differing surgery just because they might get handicapped and they might have a poor quality of life. They do differ and opt for the other easy options or other quacks options like Ayurvedic or native medicine, something like that. Later, after some time, they end up with the abdominal pain. When we reevaluate, they do have a stage 4 cancer. It's very common for us to see. please try to seek help from right professionals and opt for the right treatment at right time to cure. It's not just quality of life matters, it's the lifespan that matters. If you are just looking at that handicap part, you might lose your lifespan. This one important message I want to put. And also, if ever you have any family history of cancers, not just colorectal cancer, please consult your medical oncologist and try to seek help. It's not just to screen yourself, there is also an option of doing implantation genetic testing. So most of the families like do have some conflict because other person history is having a family history of like cancer. Can my son or my daughter will also will have such kind of children? So please seek the help. This is 2025. You will get a very good help, and your kin and kith will also be protected. And please take right help. So this is my message to all of you. And the end stage disease patients require a lot of empathy. Be it a stoma change, be it a foul smelling discharges. Please be patient and please be empathetic and try to help them. Their pain is unbearable. You cannot imagine the pain they are undergoing. Please try to be more considerate, more empathetic towards your relatives or family members who are suffering with cancer, because colorectal cancer, the end stage is going to be terrible. They'll be in a deep, immense pain which cannot be explained in words. Thank you so much for this platform to share our voice with all of you.
Right. On that note, I'll conclude this session, and I also believe that future is good, and with early detection and screening methods in place, and molecular testing, and availability of newer drugs, we would definitely increase the survival from 40% to much higher, and future is bright. Thank you so much for joining us today.
Thank you and good night to all of you.
Yeah, thank you and so much. So thankful to all of you. Good night to all of you.